Hi there. My name's Karthik Bhatia. I'm an interventional neuroradiologist. I work with both adults and children, and I work at the St. Vincent's campus across the public and private hospitals, and as well as the Sydney Children's Hospital Network, mainly out at Westmead Children's. I predominantly treat brain aneurysms, dural fistulae, arteriovenous malformations, so essentially most vascular disorders of the brain and spinal cord. Thanks for taking the time to join tonight. I know you've all been working today, so I appreciate you giving up your time. The learning objectives that were discussed with me to go over today were to identify appropriate investigations for suspected neurovascular aneurysms and to discuss the role of screening for patients with a family history of aneurysms. And I think particularly the latter is a very common question you would encounter in GP practice, and it's also something I encounter frequently. So beginning with appropriate investigations for suspected brain aneurysms, I thought we would discuss the epidemiology, clinical presentation, including rupture and non-ruptured presentations, investigations of choice, in particular imaging investigations, how to use those investigations to then do a risk assessment for your patient, and the various treatment options that are available. And then we could go on to family screening. Some background epidemiology, some basics. About 2 to 3% of the population have a brain aneurysm, so that it's a common disorder, and that rate is pretty common, is pretty constant across most populations. The rate of subarachnoid hemorrhage goes up and down depending on the genetic background, but the percentage of aneurysms is pretty constant. It's more common in women than in men, and most commonly they're detected between the ages of 35 and 60. Under the age of 30, they're uncommon, and under the age of 20, they're rare, though I do see the occasional pediatric aneurysm. They are more common in people who are smokers, with hypertension, and with a positive family history, in particular, first-degree relatives with brain aneurysms or subarachnoid hemorrhage. So why do we worry about them? We're most concerned about aneurysms because of the risk of rupture and associated subarachnoid hemorrhage. And this is an axial non-contrast CT of the brain in a patient who's had a subarachnoid hemorrhage with a classic aneurysmal pattern. That is, the blood is involving the basal cisterns as opposed to the convexities of the brain surface. And in this case, the hematoma is maximal in the right sylvian fissure. This would indicate that the most likely site for this patient's aneurysm would be a right MCA aneurysm. And there's quite extensive encasement here of the entire circle of Willis by blood on the non-contrast CT. There's also some hydrocephalus here, these prominent temporal horns, and that's one of the common early complications of subarachnoid hemorrhage and one of the frequent causes of rapid bleed.
Dr. Bhatia, sorry to interrupt. Your looks like your internet's frozen. Do you want to maybe just switch off your video and we can just use the sound? Great, thank you.
No worries. Are you seeing my slides there, no problems?
Yep, that's perfect.
Okay, great. When patients present with rupture, the classic history given is a sudden onset, thunderclap, severe headache, worst of their life, usually associated with neck stiffness and photophobia, nausea, vomiting, and then sometimes impaired consciousness due to the hydrocephalus. And if you get a patient with this kind of clinical presentation, I think it's very reasonable to call the ambulance rather than do imaging, in the community. I think it's probably more expedient if you are concerned of this kind of syndrome, call an ambulance and the CT and CT angiogram can be performed at the hospital. An exception to that might be where someone has a sudden onset thunderclap headache, but when you see them, the headache's resolved. They may have had one overnight and maybe another episode a couple of days before that, and then they come to see you. And that's a particularly concerning syndrome that we would refer to as sentinel headaches, that might be little, sharp, severe headaches that can precede the onset of a severe rupture, and usually due to like very small leaks of blood without full or complete rupture of the aneurysm. And when that happens, if you do have access to a radiology practice nearby, and you can call the radiologist and say, can we please do an urgent CT-CTA to look for blood and to look for an aneurysm, if they think they can get that done for you, very quickly, as in straight away in the next hour or so, then I think that's reasonable to help you differentiate your patient from someone who may be having an atypical migraine. At the same time, I think if you even have some concern that this syndrome is happening, it's better to be overcautious, and I don't think anyone would criticize you for sending that patient straight into the emergency department. The epidemiology of rupture is very interesting and helps dictate the way we should approach aneurysms. The reason is subarachnoid hemorrhage is actually not that common. It happens in about 10 per 100,000 people per year, while brain aneurysms are present in about 2,000 per 100,000 people. So only about 1 in 200 aneurysms would rupture in any given year. Based on those odds, you wouldn't treat many or you'd treat very few brain aneurysms if you just took those odds as they are, because the risk of treatment is significantly higher than that. But if you do take, say, a younger person, they're 40, even if they accept 0.5% per year, they could represent a 20, 30, 40% risk out into the future. In terms of rupture, when it happens, the mortality before reaching the hospital is 15%, and then the mortality in the first 30 days approaches 50%. And that's mainly due to rebleeding of the aneurysm if it's not secured. That risk of rebleeding is highest in the first 48 hours. So a general rule is, if you have a patient with a ruptured aneurysm, you don't let the sun go down on that patient. That is, if they came in at 3 o'clock in the afternoon, you would coil or clip them that evening. If they came in at 2 in the morning, then you would do the case first thing in the morning. For survivors, about 50% have moderate to severe disability. So even if you survive this 30-day period, you still have a pretty high risk of a very poor outcome into the future. So subarachnoid hemorrhage from aneurysm rupture is a very poor outcome disease. Some risk factors you can help either elevate or decrease that 0.5% annual risk, which is just a population risk, is to look at some risk factors for rupture. And one way to remember it is to use this FACES score, which is a common way of doing a risk assessment for patients with unruptured aneurysms. And the FACES score looks at a variety of features. These 6 features, number 1 being population. People of Japanese or Finnish descent are known to have a high rate of subarachnoid hemorrhage. People with uncontrolled hypertension, age greater than 70 years. The size of the aneurysm is very important. If it's less than 7 millimeters, then the risk of rupture is very low. If it's 7 to 10, 10 to 20, greater than 20, the risk goes up and very high. If they've had a previous subarachnoid hemorrhage or earlier subarachnoid hemorrhage from another aneurysm, and the site of the aneurysm is important. The highest risk aneurysms are in the posterior circulation, such as basilar tip aneurysms. Posterior communicating artery aneurysms in most of the studies are included with the posterior circulation aneurysms. And ACOM aneurysms, we also know, have a higher risk of rupture. So these 3 together are essentially the highest risk groups. MCA aneurysms are a little bit lower risk, and ICA aneurysms are even lower risk. So if you take this scoring system and you take a patient who is of Anglo-Saxon descent, they don't have high blood pressure, they're aged 50 or 60 years old, and they have a small, say 3 or 4 millimeter aneurysm, no previous bleeding, and the aneurysm is on the internal carotid artery. That patient, using this scoring system, actually has a very, very low risk of rupture of about 0.4% over 5 years, or maybe 2% over 20 years. So you can see that you can use a scoring system like this to help stratify whether your patient should get conservative management versus interventional management via endovascular or surgical approaches. Some other ways that aneurysms can present outside of rupture, which is obviously the less common way that they present these days, is incidental being the most common, and the one that I come across most in my practice. That is, usually the patient has had some kind of headache or neurological symptoms, usually which have resolved, but they had a scan as a result, and on the scan, they usually did an MR angiogram or sometimes a CT angiogram, and they detected the aneurysm. And then there's always the question, what do we do now about it? Other possible presentations. It used to be thought that aneurysms couldn't cause headache outside the setting of rupture. We now know that that is not true. They can cause a variety of atypical headaches, and you can see all kinds of headaches. Some are almost similar to migraines. Some are almost similar to cluster headaches. And we think that they get these headaches due to instability in the vessel wall at times where the aneurysm is growing. And that's usually due to an inflammatory process. It's actually common for subarachnoid hemorrhage, for example, to present in the spring. And that is thought to be due to inflammatory processes occurring in the winter, which cause inflammation in the vessel wall of the aneurysm, with subsequent instability and increased growth. Other ways they can present, particularly cavernous aneurysms when they get large, can push on the cranial nerves going to the extraocular muscles and cause ophthalmoplegia or diplopia. Those aneurysms actually very rarely rupture because they're outside the dural covering, but they can press on those nerves and therefore need treatment. Actually, ischemic stroke is more common than you'd think associated with aneurysms. And that's usually due to some clot forming within the aneurysm and then little emboli flying off from that clot. And so sometimes I will see patients with ischemic stroke as their presentation or TIAs, and I would put them on aspirin before considering further treatment. Rarely, if they get large enough, they can cause seizures or mass effect, but it's pretty uncommon. And the other way they can present is they may come to your practice asking about whether they should be screened because one of their relatives had an aneurysm or a subarachnoid hemorrhage, or if you have patients with autosomal dominant polycystic kidney disease who are at higher risk of developing brain aneurysms. So what investigations would you order? If you are concerned that there's been a rupture, I would send them by ambulance to the nearest hospital, and there they would get a non-contrast CT to look for the blood, a CT angiogram to look for an aneurysm. If there's no blood on the CT, but the story is very typical, and usually that would be the case if the presentation was delayed by 2 or 3 days, and therefore the blood is no longer visible on the CT, then you can do a lumbar puncture and send the CSF off for xanthochromia to look for the breakdown products of the bilirubin, which would have from red cells which have broken down. And that's much more specific than just looking at the number of blood cells, because obviously if you have a slightly traumatic tap, then you may get a confused diagnosis. If you have a question mark sentinel bleed, as I discussed, I think CT and CTA is reasonable, and if you think you can get it done very quickly. And if you ended up getting a patient who you thought had a sentinel bleed or an atypical headache, you did the CTA, you found an aneurysm, but there was no blood on the CT, my protocol would probably to call the neurosurgical registrar or any neurosurgeon you know at your local hospital and just tell them the story and say, look, I'm concerned about this patient. They have this atypical headache. Can we get them admitted either through emergency or straight through your rooms so that we can organize an LP and go from there. The other way that you can investigate these patients who are presenting less acutely, say with atypical headache, ophthalmoplegia, or screening for family history, is I would recommend an MR angiogram, and I'll talk about that in a second. I like MR angiography for a few reasons. One, there's no radiation, no ionizing radiation, so no risk of malignancy as a result of doing the scan. And therefore, it's very good for doing annual scans and following up patients who have aneurysms. It's very sensitive, even down to 1 millimeter sized aneurysms. You get very nice 3D reconstructions like this one, and you can see this rather tiny aneurysm on the ICA here on the right. You can actually follow that year after year with MR angiography. You don't need to give contrast, and that's a real benefit because that means the patient doesn't need a cannula. You don't have to worry about their renal function because MR angiography within the brain, the most common way to do it is a technique called time of flight angiography, which is using the directional flow of protons in the blood to help create this map. And as a result, you can get very high quality pictures without having to give contrast. As a result of not needing that, you don't need to worry about bolus timing, which is a problem when you do CT angiograms. If you get the timing wrong for when you do the scan, then sometimes you have to repeat it, and that means a second load of contrast, more radiation. And the other thing I like about it is that if the patient has had a previous coiling, MR angiography isn't really affected in a bad way by artifact from the coils. Clips are not so good with MR angiography from neurosurgical clipping, but for coiling, MRA is very good. When would you do CT angiography? You do that when you want a faster answer. It can be, harder to get an MRI in a hurry. Sometimes you'd be very lucky, or you have a very good practice nearby who can fit in an MRI that same day. But a CTA can almost always be fit in because it's a relatively quick thing to organize. You don't need to do a screening questionnaire for the MRI. So it's quite easy to do. When you want to see acute blood, getting the non-contrast CT will show that very clearly and very quickly. It's also useful for patients with pacemakers. A lot more pacemakers now are MRI compatible, but before you turn off the pacemaker and have an MRI, you usually want to contact the cardiologist, and then you have to get the rep from the pacemaker company to come in and switch it off before the MRI. So it's not a, you can do it if you have to do it, but it's not an easy process, and certainly not something I would do in a patient I was acutely worried about. When you want the bony anatomy, that's a good reason to do CTA, and that's why surgeons in particular like to do CTA. So if you had a patient in whom the aneurysm was detected on MRA, you refer them to a neurosurgeon and they asked you to organize a CTA, the reason is usually because they want to know the relationship of the aneurysm to the anterior clinoid process to help determine if it's intradural or extradural, and also if to help plan their operation in terms of their craniotomy. So me personally, doing endovascular work, I don't see much advantage to doing a CTA, but certainly if the plan is for open surgery, then the surgeons will often ask for a CTA. And if there is a surgical clip in the patient from a previous ruptured aneurysm or unruptured aneurysm that was treated, then CTA is less affected by the clip than MRA. So patients who've been clipped, we often send for CTA. The MRA is also getting better at that, so I'm not too fussed. And then the third investigation you can do is when do you organize a formal angiogram, and that's something done by people like myself, interventional neuroradiologists. And that means catheter angiography via either radial or femoral access. The main reasons to do that are for treatment planning and post-treatment assessment. So essentially, I don't think as a GP in the community, you need to worry too much about organizing a formal angiogram. I think that if you've picked up an aneurysm on CT or MRI and you've referred them on, then the neurosurgeon or the INR like myself will tend to organize the cerebral angiogram from there as needed. And so this is a picture you can get from a digital subtraction angiogram where the patient has a giant cavernous segment aneurysm. Here is the cavernous segment of the ICA, and you can see this enormous aneurysm, which is actually extradural. So it lies outside the dura and is very unlikely to cause a subarachnoid hemorrhage. But this patient presented with ophthalmoplegia because this is in the region of the cavernous sinus and it's pushing on the adjacent cranial nerves. And the way to treat this kind of lesion would actually be to place a flow diverter across here to reduce the flow into the aneurysm and slowly let it block off over 3 to 6 months. And that's how we treated this one. When you do a formal angiogram, you can go radial or femoral. I do a lot of radial access these days because patients find it more comfortable. They can sit up afterwards, and we just deflate the band on the wrist over about 2 hours. And so I find patients are more comfortable afterwards. There's also lower access like complications. That being said, sometimes you can't get every vessel you need to image from the radial access and you have to convert to femoral. So there are some patients in whom I may have seen the CTA and can see I might need a specific vessel or a specific view, and I might advocate for femoral. Similarly, I've actually got a lot of teenage patients who prefer femoral access because they prefer to be able to text after the procedure. So increasingly, a lot of the teenagers in whom I've done radial access before have asked me to do femoral for the next one because they're happy to lie down for 4 hours. You can do the procedure under conscious sedation in adults, while in children I tend to do it under full general anesthesia. And overall, the risk of the procedure, the major risk is a 1 in 200 risk of stroke, up to a 1% risk of a TIA, which resolves itself within a few minutes. The investigations you've done can then be used to perform a risk assessment. And there are 3 main ways to do a risk assessment for an unruptured aneurysm. One is to use the FACES score, which we went over before. And based on that score, which is based on a meta-analysis of previous studies of unruptured aneurysms and their follow-up, it gives you a 5-year rupture risk based on the score that you get. So for example, the example of the very small aneurysm in a patient who is under the age of 70, who has no other risk factors, would have a 0.4% 5-year rupture risk. And I think when you're dealing with such low numbers, conservative treatment is a very good option for these patients. And when you take the 5-year rupture risk you get out of the FACES score, you can then compare the risk of treatment with the rupture risk, and you can also look at the patient's life expectancy. And you then put those together to give a recommendation to the patient. If I expect the patient to live another 30 years, that is, I'll multiply this number by 6. If that is approaching somewhere between 5 and 10%, I probably would be more likely to offer treatment. If it's only approaching maybe 1.5 to 2.5%, I'd probably be pushing more towards conservative treatment with annual MRI, wait and watch approach. A second way to assess patients with a risk assessment is a more complex score called the UIATS. So if you're in your practice, I recommend going for the FACES score. They're actually web calculators. So if you want to do this in your practice, you can go online and just Google FACES. And there are a number of online calculators. You just put in the details, it will give you the number out. And it's at least a little quick assessment you can give the patients. While the UIATS is more complex, it's basically a one-page thing you have to fill out with checkboxes. But at the end of it, it gives you, instead of giving you a rupture risk rate, it gives you a score in two columns. One column is the score in supportive treatment, and in the second column is the score in supportive conservative management, depending on where you tick the boxes. And if there's a difference of more than 3, that's considered significant, and that points you towards whether you should be offering treatment or offering conservative management. And the third way to do a risk assessment, which I do more and more of, is MRI with vessel wall imaging. So ignoring what I just said about the fact that you don't need to give contrast to do an MR angiogram, if you have a patient with an aneurysm and you want to do a further risk assessment, you can give gadolinium and use special imaging techniques where you basically subtract out the signal from the blood vessels and you want to look only at the wall of the vessels and you look to see if that takes up gadolinium. And if it does take up the contrast, that's an indicator that there is inflammation in the wall and instability. And there is some increasing evidence that when you see instability in the wall, those patients are more likely to have a rupture or growth in the coming 6 to 12 months, as opposed to patients who have no enhancement in the vessel wall, in whom usually you see no growth. One recent study showed that out of 19 patients who had vessel wall enhancement, 4 of them, so about 20%, went on to develop either a rupture or increased growth of the aneurysm. While in the other group without enhancement, about 50 of them, none of them had any growth or rupture in about 4-year follow-up. So it's a useful way to take these scores and provide yourself with a little more assurance. We do a lot of vessel wall imaging here at St. Vincent's, and I do it mainly at the public hospital, where we've got a protocol set up. So if you ever have patients in whom you'd like to get a more accurate assessment, please send them through to us and we'd be happy to organize MRI with vessel wall imaging. So this is an example of vessel wall imaging. Here's an MRI scan, and this is a patient who had a initially unruptured aneurysm. They, and this is from that study I told you about. Here is what we call black blood imaging, where we null out the signal from the artery, and you can still see the aneurysm here off the right MCA. When you give gadolinium, you can see there's some very faint enhancement in the wall. And then when you then look here at baseline, the size of the aneurysm on the MR angiogram was about 4 millimeters. This patient then presented with rupture down the track, and at that time it had increased in size and was associated with extensive subarachnoid hemorrhage. So this is an example of the predictive possibilities of vessel wall imaging, though I think it's going to need more extensive studies in the future to really prove its value. So you've done your risk assessment and you've basically come down with what you think is the percentage risk of rupture over the next 5 years or the next 20 years. You've looked at the patient's life expectancy, and then you look at the potential treatment options. If you have a patient with a very low risk, conservative treatment with an annual MRI, and I would do that with vessel wall imaging so I can keep a track of any instability, and then follow up clinically after the MRI each year, is a very reasonable approach. And I've sent a number of patients down this pathway. Endovascular. Endovascular is the kind of treatments that I offer, where we go via either radial or femoral access with the patient asleep. You can do just standard coiling if the aneurysm has a narrow neck, stent-assisted coiling if it has a wide neck. That usually requires the patient to be on dual antiplatelets for 3 to 6 months, and then aspirin alone for up to 12 months. And after that, I often keep people on aspirin if they're tolerating it, but if they have to stop it for example, extensive dental work or something, then there's no problem, we can do that. Flow diverter, which is a special stent with very small pores, which you put across the neck of big aneurysms or hard to treat aneurysms, and it slows down the flow into the aneurysm while maintaining normal laminar flow within the parent vessel. And this is a very useful technique for those giant cavernous aneurysms or other atypical wide-necked aneurysms. These also require dual antiplatelets, and usually for longer, you have to be a bit more cautious. The other problem with flow diverters is that yet they're not covered by insurance companies, and they're also, some hospitals will not cover the cost of them, and they can be out-of-pocket cost of around $10,000 to $12,000 for the patient. But sometimes we can convince the public hospital to pay the cost of it, and as a result, I do offer it where I can, but it is an expensive option, though very effective. And then intrasaccular devices are very popular now and becoming more and more popular. And that's almost like coiling, but it's like a little cone-shaped or balloon-shaped device that you deploy inside the aneurysm. And it basically acts the same as coiling, but it's a much simpler procedure to do. And it also covers the neck of the aneurysm much better. And then the third option is microsurgical clipping, which is done by neurosurgeons. And microsurgical clipping is less and less common, basically because a large study, the ISAT study, demonstrated that endovascular treatment was associated with better long-term outcomes clinically than microsurgical clipping. If you ask a neurosurgeon about that, they'll have many criticisms about the study, but that study was done in the 90s and published in the early 2000s. And since then, we've come even further with endovascular treatments with all these different options. Back then, it was coiling alone, and that was it. So I think that in terms of this debate between endovascular and clipping, endovascular is very, very common now, and you'll even see neurosurgeons going on to do fellowships in interventional neuroradiology because even they're accepting that endovascular is the way of the future. Some aneurysms which are still, the recommendation is still for clipping would be MCA aneurysms because they're close to the external surface of the skull, so relatively easy for a neurosurgeon to get to, and they're often wide-necked, and they often have branches coming off their neck, harder to preserve during endovascular treatment. So most neurosurgeons would advocate for clipping of an MCA aneurysm of an appropriate size. That being said, these intrasaccular devices are now starting to create some competition on that front as well. So then I thought I'd move on to family screening, but are there any questions at this stage that you wanted to ask me about investigating aneurysms?
We don't have any questions at the moment, but we'll let you know if any do come through.
One. So then I thought we'd talk about family screening, and we can discuss who should be screened, who should consider screening, and what are the advantages and disadvantages of screening. So when we say screening, what I really mean is, excuse me, what I really mean is to do an MRI to look for an aneurysm in a patient who is asymptomatic based on their family history or based on the presence of a disease such as autosomal dominant polycystic kidney disease. The risk of aneurysm development is higher in patients who have a positive family history for either having an aneurysm or having a subarachnoid hemorrhage. If you have one first-degree relative, that is sibling, parent, or child, who've had a subarachnoid hemorrhage or an aneurysm, your risk of developing an aneurysm in the brain is about 8 to 10%. If you have two first-degree relatives, then the risk is about 15 to 20%, or a relative risk of 6.6 compared to the rest of the population who have a risk of 2 to 3%. If you are female, then your odds ratio is 2.5. So female patients who have a positive family history are significantly more likely to develop an aneurysm. If you are female and you have just one first-degree relative, but you are also a smoker or have hypertension, that risk is 25%. Smoking alone has an odds ratio of 3.2 of developing an aneurysm if you have a positive family history, if it's over 20 pack years, and high blood pressure, a slight increase, odds ratio of 1.3 if it's been present for more than 10 years. The risk is not equal amongst all first-degree relatives. The highest risk is amongst siblings, brothers and sisters, followed by children, and then parents. So if I did have a patient come to me and say they have two first-degree relatives, or they have an aneurysm and their brother has an aneurysm, and they're asking me who should be screened in their family, I would say first up, we screen any other brothers and sisters you have, and then we screen the children. And probably the least important group to screen are parents. The pickup rate is much lower. If you have a positive family history of intracranial aneurysms, the lifetime risk of developing a subarachnoid hemorrhage, so not just having an aneurysm, but having an aneurysm with a clinical consequence, is actually about 5% for first-degree relatives and 2% for second-degree relatives. So not that high, but significantly higher than the rest of the population. The 10-year risk is obviously lower than that, 1.2% first degree, 0.5% second degree. But this is where screening becomes controversial, because while you might have patients who are at high risk of developing an aneurysm, only a small proportion of those will actually go on to have a subarachnoid hemorrhage. And we estimate about 1/5 of patients who are screened, 1/5 of patients who have a positive family history and have an aneurysm will have a subarachnoid hemorrhage, and 4/5 will never have a subarachnoid hemorrhage. So this is why screening becomes a bit more questionable. So the current recommendations are 2 or more first-degree relatives with a subarachnoid hemorrhage or a brain aneurysm. Then screening should be offered, ideally using MR angiography to avoid radiation and contrast, and then repeated every 5 years to look for de novo aneurysm development. Doing it more often than that is not of a very high yield if you're just screening, so every 5 years. And then I would advocate going siblings first, then children, and then least important in that equation would be parents, though still offer it, and if they're not particularly inclined, then you didn't chase it too much. If there's one first-degree relative only, screening is not recommended at a population level. That is, if you have one patient, so if you have a patient who has one first-degree relative with an aneurysm, and they ask you whether their whole family should be screened, you wouldn't advocate for that. What you would say is that if there is anyone in your family who's particularly concerned, then we can discuss screening, because that might be reasonable, but you just wouldn't recommend a widespread screening for the entire family. So if you think you have someone who would like to pursue this further, I tell them that they probably have an 8 to 10% chance of developing an aneurysm, but there are benefits and risks of screening, which I'll go on to in a minute, and they then have to make an individual decision as to whether they want to go down the screening pathway. For patients with polycystic kidney disease, the adult version, the autosomal dominant version, about 9 to 12% of those patients will have a brain aneurysm. And screening is debated in that population, but the current evidence suggests that doing a 5-yearly MRI is the most cost-effective approach to screening in this population, and the most effective for picking up aneurysms as well. There are risks of screening. When you screen a patient, what you find out is that if they screen positive, they tend to get a reduced quality of life, they tend to reduce their work hours, and studies into it have shown they have reported reduced self-esteem and independence. So it's not a small impact on their life. When patients have screening and they're negative on their screening, they don't tend to have these features. So when you screen someone, they have to be aware that the test could come back positive, and if it does come back positive, even though some people will be assured by the fact that they might be able to pursue treatment or watch their aneurysm annually, many patients, it will impact their life in some way. However, out of all of these patients, regret is actually quite uncommon. The studies suggest that only 2 to 3% of people actually regret going through the screening process. One of the complex areas is, what if you screen a patient, they're positive, and you find a very small aneurysm, like a 1 or 2 millimeter aneurysm, or even a 4 millimeter aneurysm, that would generally not be considered suitable for treatment. The evidence is mixed, but the most recent evidence suggests that there was no moderate severity depression or anxiety in this group. And so in general, I don't think screening is bad as it was once made out, but I have to advise patients before we screen them that these are the things they could face, and they should really talk with their family, have a think to themselves whether they're happy with the idea of finding an aneurysm and then being told that that aneurysm shouldn't be treated and we should watch it every year, and if they're okay living with that. And some people would prefer not to know, and in those cases I don't advocate screening if they only have one first-degree relative. So in summary, aneurysms are common. They affect 2% of the population, but only 1 in 200 of those would rupture in any given year. Rupture is associated with a high mortality. Of the patients who survive, so of the half who survive, half of those have long-term moderate or severe disability. So it's a serious condition when it ruptures. Suspected rupture presentation, the best approach is to call an ambulance. If you think you have a patient with a severe sudden onset, worst headache of life, meningism and nausea and vomiting, I would call an ambulance and send them to the hospital where they can have a CT plus CTA, and they may or may not require an LP. If you're worried about a sentinel bleed and you can get a CT, CTA quickly from your local radiology practice within the next couple of hours, I think that's reasonable. And then you can discuss the case with a neurosurgeon. If you're more concerned, send them by ambulance. More subacute to chronic presentations or screening presentations, then I think MR angiography is the test of choice. No radiation, no contrast, very repeatable, very useful. Of course, you'll have the occasional patient with a pacemaker or severe claustrophobia who are not happy to have MRI. You could do a CTA in those patients, that's reasonable. But my first choice is always MRA. Based on the imaging tests and the clinical features, you can do a risk assessment for the patient to decide on treatment using the FACES score, which I think is the simplest one to apply in your GP setting. The UI-ATS score, a bit more complex, but useful to kind of confirm your decision. And vessel wall imaging to look for additional information on instability in the wall. And then you offer treatment options, the watch and wait approach with annual MRI, which is a very reasonable approach, endovascular treatment, which is the most commonly performed treatment for aneurysms now and increases every year, and surgery, which is decreasing but still plays an important role. And for family screening, the recommendation is to undertake screening in patients with 2 first-degree relatives. If there's 1 first-degree relative, I recommend a consultation with someone like myself before undertaking screening to discuss the pros and cons. And that's all I had to talk about tonight. If there's any questions, I'm very
generally about the basis of neuroplasticity, or why stroke rehabilitation works. And then I'm going to present a young person with a stroke as a case study, and I'm going to try and introduce concepts of stroke as a chronic disease, and offer some clinical challenges in general practice. The first thing is the basic tenets of neuroplasticity. This is why stroke rehabilitation works, is that the brain can reorganize itself, particularly in the early phases following the stroke. The second aspect is that the size of the stroke and the position of the stroke are very important with respect to your chances of getting them improved. And there are benefits of organised stroke rehabilitation care, which I'll talk to you a bit about, and I'll talk to you about timing, intensity and task specificity of training, and the importance of rehabilitation for even very severe strokes. So in 1949, it was known that if you gave rats strokes and you put them in sort of play environments as opposed to a small box, they develop very enriched dendritic connections around the stroke. So as you can see here, this is the dendrite and the axon of a living piece of brain around a stroke in a rat that had been put in a cage with wheels. And this is the one where the rat was just put in a small cage. And you can see how more rich the connections are. The second thing is that there was a reorganization of the affected hemisphere. And what was found is that the same sort of skills that, for instance, we use to teach children's sports or dancers choreography, we could use those same sort of skills in teaching people following a stroke with a hemiparesis how to regain walking. And they noticed that the cortex following the stroke had reorganized itself. And the reason it reorganized itself is because the amount of brain around the stroke area that was still alive allowed itself to be reorganized, which is why it's so important that we work with acute care physicians to preserve the amount of brain that survives, either through thrombolysis or through clot retrieval. So this is a study that Nudo did in monkeys. So this area here is where the stroke had occurred, and this is part of the homunculus of the monkeys, and this shows you what part of the motor strip was dedicated towards the hand and which part was dedicated towards the elbow and shoulder. Now, if you did no rehab at all for the monkey, there was the lesion, and the area that usually controlled the hand shrunk, and there was a greater area of control for the elbow and shoulder, as if it somehow took over the area from the weakened penumbra, or the area around the stroke. And it left the monkey with very poor hand skills, so it couldn't feed itself. then if you gave the same lesion to a monkey and you put it in rehab, the hand area actually expanded to allow the monkey to reuse its hand again. The shoulder and elbow area sort of diminished a bit, as if the area around the penumbra could actually reorganize itself and give itself more of the motor strip to use. So the concept was use it or lose it. So you put the rat into a complex environment, it runs around, and it then developed better use of the hand than the ones that you put in a cage. If you actually did something even nastier, which was after a stroke with a rat, you let it use both hands, but with another rat, you actually tied up the affected hand so it couldn't use the affected hand, you could see that the impact on the surviving nerves around the stroke area showed that one got much more opportunity to connect with other living neurons and the other one did not. So Running and Golvig did a study which now would be unethical, which was essentially in the late 80s and 90s, stroke was considered a condition that was not to be treated, and that actually persisted in some parts of Europe for a bit longer than in Australia and the US. So they randomized patients between going to a rehab unit or an inpatient rehab unit or going home. So they just sent them home after they had their stroke. About 40% just went to a nursing home, 30% had occasional outpatient therapy, but the remaining 30% had no formal rehab treatment. And they followed them up for 7 months. And they found that the number who were dependent or dead were much less in the rehab group than in the community group. And there was a 39% reduction in worse outcomes. So this was one of the basic research studies that showed the importance of stroke rehabilitation. But you can see that if you took his numbers and you just look at mild stroke, there wasn't much of a difference in the number of people who were dead and dependent. There still was slightly more in the community group, but it wasn't actually significant. But if you looked at moderate severe group, there was an enormous difference in the number dead and dependent in the community group versus those in the rehabilitation group. So it became clear that particularly for moderate or severe strokes, rehabilitation was a significantly important area to address. And then in another study by Indravik, where he got 220 acute strokes to stroke units or general medical wards, he found that those who went to stroke units had less mortality and much better outcomes. So in his study, if we look at all the strokes, you can see that the number who were dead in the medical unit were much greater compared to the stroke unit, and the number who had to go to an institution were much higher in the medical unit as compared to the stroke unit, and the number who went home was much lower in the medical unit compared to the stroke unit. So there was still a significant benefit found at 10 years out. So getting into a stroke rehab unit and into an acute stroke unit where you get rehab, it was actually very beneficial out for a long time. So the next question was, is it better to do the rehab early or late? And it was found that the brain was primed to recover in early studies. So in Bernansky's study, he subjected the rats to rehab in 5 weeks. Some began at 5 days, some began at 14 days, and some began at 30 days. And they are all after a small stroke, and the control animals were just put in social housing. The outcome was whether the animal could grab this pellet. And so all received 5 weeks of rehab, but the ones who got it in day 5 got a marked improvement in getting the pellets. The 14-day ones who had to hold off till day 14 got a moderate improvement, but after 30 days there was no improvement. And there was corresponding cortical reorganization in the brain around the stroke. So treating the brain early was actually significant. However, in one of the largest international trials in stroke rehabilitation done in Australia by Professor Julie Bernhardt, published in The Lancet, with about 2014 patients, showed that if you mobilise people within 24 hours of the stroke, they actually had worse outcomes, and you had to wait till about 20 till the second day. Now, partly this is due to the design of the study, and also partly is due to leakage. What was happening was that people were seeing that the ones who were getting the early exercise were doing better, and so the control group started to merge into the treatment group, and so the study was a bit affected by that. Now, the next question is intensity of therapy. How much do they have to have? And the bottom line is the more you can get, the better. And so the greater intensity of therapy was actually produced better outcomes, particularly for speech or walking or upper limb use. In a large study of middle band or moderate strokes that were either going to go to a stroke unit or a general medical unit, Calra looked at the intensity of therapy, and he found that those who went to the stroke rehab unit who got more intense therapy improved. This is a measure of improvement. They improved more rapidly than those who went to the medical unit. But what was interesting, is that the number who went to the stroke rehab unit got home earlier than the ones who went to the medical unit. What was interesting was that the intensity of therapy was fairly much similar, but in the stroke unit, you got it more at an early phase. And if you got it on an early phase, you got these very good results. So altogether, there was about the same amount of physio and OT in both groups, but in the stroke unit phase, they got it in the early phase. So now I want to present a really interesting case that we've had in recently, a 27-year-old unemployed musician who had a post-auricular or occipital headache. And he presented to the hospital with dysarthria, a right hemiparesis, right facial droop, drooling and difficulty swallowing. He's had no neck injury or trauma, and he admitted to 2 cones of marijuana, but his drug screen actually showed that he had used amphetamines. He had a past medical history of bipolar disorder and a lot of recreational drug use, and he was on Abilify, which is an antipsychotic for bipolar disorder. So a CT angiogram was done, and he actually had a right vertebral artery dissection. So this is where the actual blood vessel was torn, and it gave him a right posterior inferior cerebellar artery infarct, which is essentially a funny way of saying an infarct to the cerebellum and to the medulla. And he also had a right posterior inferior cerebellum infarct. So he actually had his cerebellum infarcted and a bit of his medulla. And he had thrombolysis with TPA, but his urinary drug screen came back as positive for cannabinoids and amphetamine. And I'm going to talk to you a little bit about the impacts of those 2 drugs. He had a sudden drop in his GCS after a few minutes after the TPA. So I can tell you there was a few neurologists wanting to change their underwear at that point. And he went intubated, and a repeat CT perfusion showed actually that it had all worked and that he had simply had a bit of swelling. So they got the neurosurgeons about because they thought he was coning, and he actually was coning because bleeds or infarcts underneath the tentorium or in the posterior fossa can put so much pressure on the brainstem, it can push the brainstem through the foramen magnum or cone them. And so you've got to be ready to have a decompressive neurosurgery. But fortunately, they watched him in ICU and he improved, and they didn't have to do anything. So in the bottom at the end, he had a right cerebellar and lateral medullary infarct. And there were some small areas of hemorrhage within the medulla. So he had a tracheostomy inserted, so he was not a well boy. He had a nasogastric tube inserted because he couldn't swallow, and he had extremely high anxiety and suicidality. And he was recommenced on his Abilify, but progress showed that he had some secondary edema, but he actually progressed, and the tracheostomy came out, and he's got an NG tube in, and he came to the rehab unit. Now, his rehab issues, which are going to actually continue in general practice, and you guys are going to have to manage it, is dysphagia and his nutrition, his ataxic gait and high risk of falls. He's going to have impaired coordination of his limbs, so driving is going to be a real issue, and you're going to have to face all that. His mood, his employment and housing are going to be great issues, and drug and alcohol issues are going to be significant. The anxiety medications that he was on is piprazole. He went on to gabapentin because he got neuropathic pain, and so that's not uncommon in subcortical strokes. And he got a meprazole. And why did he get a meprazole? Well, he couldn't swallow. So what we're worried about is that he was getting reflux, and as you get reflux and mucus comes up from your stomach and gives you water brash, in these cases they'll inhale it. So the idea is to give them some meprazole and maybe even some metoclopramide to try and empty their stomach. He had to go into Clexane, which we're all a bit nervous about, but he wasn't walking, and the hemorrhages in his brainstem had settled down. But here were the main issues, the psychosocial issues, the ones that we all deal with and you deal with in general practice more often than other specialists in family care. So he lives alone. He has a half brother in Redfern. He doesn't get on well with his mother, and her partner live in Neuro. He works as a musician and he plays a lot of instruments, but he was on job seeker at the time, and he was planning to stay in Neuro with his mother. So he's going to go regional, where there's probably less sort of resources. But previous to this, he was completely independent. So the question is, he's got dysphagia, he's having trouble swallowing. Is he aspirating? And what's his chest hygiene like? And can you aspirate saliva? Well, the truth is you can. And 30% of people who aspirate their saliva don't have a problem, but 70% of people do. So you can aspirate your saliva. So the question is he getting pneumonia? And the other question is he losing weight? He can't eat, so he's got an NG tube down and he's got feeding going on there. But he wants to eat, and can he safely eat? And if he can eat, he'll have to have thickened fluids and soft food. And will he be compliant? In this case, you know, a young person with a drug history, maybe not. And those with persistent dysphagia, are they allowed to eat and sacrifice the occasional aspiration pneumonia for eating a normal diet and then be able to choose their own menu? So I've had a couple of patients who've said, look, I'm never going to be able to swallow properly. I want to be able to taste food, and I'm going to taste food and eat food. And if I get pneumonia a couple of times a year and I have to go to hospital, I'll wear it, which puts the general practitioner in quite a difficult spot, but there's ways to manage it. Now, can you teach people to swallow? Yeah, you can, but it is a very hard thing to teach, and it takes a long time often to come back. What about his voice? Because his voice at the moment is very gurgly because he's actually not able to swallow a lot of his saliva, and it sits in at the top of his vocal cords. So here's a now I hope this works. I think it's going to work. I'm going to show you a modified barium swallow. What we're looking for, when you'll see he'll swallow some, and it's a video, and what we're watching for is the food should go down this wire. Well, it's not a wire, it's a marker in his NG tube. We want to see the food go down there, but sometimes it'll go forward. So there it is there, sitting around his vocal cord, but it didn't go forward. It sort of stayed there. Oh, there it went. And here's the problem. I'll just show that to you again. And I'll show you something very dangerous about this episode. There's the food in the spoon, and there it is going down the normal area, but there's a bit hanging around his vocal cords, and there it is hanging around his vocal cords, and on his third swallow it goes down. But here's the issue: no coughing. You can't see him cough. He doesn't even know he swallowed. So the issue here is he's a silent aspirator. So, oops, I want to go through. So what you have to do in general practice when you've got a person with long-term dysphagia, they'll either have an NG tube, probably not. They'll probably have a PEG tube in their tummy, and they'll be getting their food that way. So you have to partner with a rehab service or at least a speech pathologist and a dietitian. And what your job in general practice is to monitor his chest hygiene, because he can get an aspirational at any stage. And sometimes it presents with him just feeling a bit off. So you should always suspect the chest. Watch his weight. If his weight's dropping, he's not eating. And then if he gets the occasional pneumonia, watch for him not to develop bronchiectasis. Swallowing can be taught, but it might take months to improve. And he's got to, in this way, we teach him with EMG on his platysmus muscle and his hyoid muscles, because they raise and lower the cricoid cartilage to help you swallow. And we teach them, we get them to watch a screen and say, yes, now you're swallowing well, you get that feeling, try it again. We also teach the Mendelssohn swallow, which is a double swallow after eating, and we also strengthen muscles in the face. We also will train the partner to supervise the correct head posture, which is flexed rather than open, because you don't want to open the airways. What we do when we resuscitate people to let air get in, we want them to close the airway so that the food can get up the back. And what about the ethics of swallowing? If the patient has capacity and they can identify when they have pneumonia, should they be allowed to eat for comfort and to allow them to taste food? And this is a question you need to put in with the patient, talk to the patient about. When you have a look, a fibre optic examination of swallow will allow you to look at the cords. Now, this cord here is normal because you're getting it to come into the middle to adduct when someone swallows. This left cord is not moving across, right? It's not moving across. The left cord is paralysed and the right cord is normal. Now, we need to notice that because if it's paralysed, you can put in a fake cord and let the other one close it. And if it's spastic, you can give it Botox. But these are things that you need to be aware of so that if things that happen in general practice, you can be aware of it. So here's a picture of aspirational pneumonia, as you can see it. And here is a more obvious but more chronic aspirational pneumonia. And here's a classic CT with bronchiectasis. Okay, the next issue is ataxia. Now here's a sad story I'm going to tell you. Cerebellar dysfunction does not respond that well to physical rehabilitation. And the reason is that you use your cerebellum to imprint your learning. That's how you learn to dance. That's how you learn to tightrope walk. You walk normally, but you imprint that learning in that situation on your medulla, and it has a diaschesis or a connection to your motor strip. And that's how you sort of imprint it. So it doesn't really respond to rehab. There's a couple of studies using transcranial magnetic stimulation and direct cortical stimulation, but they're experimental and we don't know much about the outcomes. So our approach is compensatory. We teach them how to use their eyes to get a better idea of their mobility and balance. We train them in front of mirrors, and that's why lighting at home is so important when they go home. We give them usual falls prevention, which is quadriceps training, osteoporosis management, home safety and lighting, gait aid for crowds. So we tell them, look, you're going to fall over with whatever gait aid you have, whether you have a stick or a frame. But if you have a stick and you're in a crowd, people will stay away from you and you can hit people if you need to. And we teach them falling techniques and getting up off the ground techniques, and we manage their comorbidities. Here's the inferior cerebellar artery. This is the one that was blocked, and you can see it offers a little bit of blood supply to the cerebellum, but it also provides some to the medulla. The anterior or aeca also provides a little bit of blood flow here to the medulla, to the cerebellum. The superior cerebellar artery does a better job. It just provides a little bit of supply to the cerebellum. It doesn't actually supply the midbrain, so it's a little bit better in terms of causing damage. But you're left with somebody with fine motor skill problems. So they have problems with feeding themselves. So they often need assistive devices. So for instance, there's a spoon with a gimbal. So what happens is if they've got tremor, the actual spoon vibrates opposite to the tremor and keeps the soup in the spoon, and they can drink it down. You need an OT to get one of those. They're about $400, but they do work. you need to look at their ability to dress, whether they can do up buttons or do their zippers. And you'll find if you notice your patient coming in tracksuit pants and a sloppy Joe, you're getting the idea that they're not as good at bras and belts, things like that. We teach them task-specific training. So we teach them how to put on bras and belts, and if the function of their hand is really poor, we will give them modified clothing with Velcro straps and things like that. Interestingly, in gaming, using Wi-Fi and things like that to do the Wii actually helps in hand function. And we also, this guy's been a musician, so we brought all his musical instruments into the ward so he can practice playing the guitar, and he's often quite a lot better when he does that. The other thing is driving, right? So driving's a big deal, so I'm happy to answer some questions about that. But driving will require a driving assessment with an OT because the function of the hand and the ability to grab the handbrake and put your foot on the brake is critical. So you'd need to have an OT assessment. This is a device we're using at the moment. I'll just show you a brief. Have I got time to show this? Can you guys tell me if I've got time?
Yep.
Yeah, okay, so just be a few moments, and it shows you how we're using assistive technology in the rehabilitation space. These are the major things that you guys are going to have to grapple with, and as we do in rehab, and we really are available to be partners with you to handle a lot of these problems. The psychosocial needs of young people with complex disabilities following a stroke are enormous. Thankfully, and thanks to Bill Shorten and Julia Gillard and our current government for supporting the National Disability Insurance Scheme, what a complete game changer that is for the young stroke. Now getting cash and assistance, housing if required, and full-time care if required, they're in a much better position than they ever have been. One of the ideas of the NDIS is to assist, I guess the next thing to talk about is the psychosocial needs. And the psychosocial needs are going to be fairly big. We've got the NDIS. Now, the NDIS, I'm happy to take questions about, but they should actually be able to assist these patients in being able to manage at home. But most importantly, people with posterior fossa strokes don't have cognitive features as much. They do have some cognitive features early on, but they improve. So their ability to return to work is quite good. And they need special occupational therapy to assist them. And in fact, the NDIS has a whole unit assisted aim to get younger people back to work. The whole aim is to get people back to work to pay taxes, to pay off the NDIS. But perhaps the issues are the drug and alcohol issues. Now, cocaine and amphetamines, the neurostimulants, are more likely to cause vasospasm in blood vessels in the brain, particularly cocaine, ice and ecstasy, and amphetamines. Marijuana, interestingly, has been associated with an increased risk of strokes, but it's an association, and I'm wondering if that's because a lot of marijuana users are polydrug abusers. But in one study, in an American study, even when they held all the other drugs separate, they reckon that marijuana can itself cause a spasm of blood vessels in the brain, but they're not sure how. Its odds ratio is about 1.6, so it's about gives them 60% extra chance. Thankfully, stroke in young people is rare. So that's got to be addressed, and certainly drug use in young people is really hard to manage, and same with alcohol use. But I would say to you that their time using amphetamines, ice and ecstasy has got to be over. The other drugs would be you'd have to manage as you can. In terms of supported living, they need to have a house that's been assessed by an occupational therapist, so they will be falling over, people with persistent ataxia, about once to twice a year, hopefully not breaking bones. So you need to make sure that there's no risk of osteoporosis, they're not smokers, you're not on steroids. But perhaps the most important thing is the perception of mood particularly in those with high risks of mental illness. So mood, in around about 33 to 45% of stroke survivors in the community, post-stroke depression develop. So this is quite common, and it masquerades, as you know well, in so many forms. So in the young person with a subcortical stroke, you've got to have a look at their mood, their drug use, their alcohol use, and then also be mindful of the possibility they might have sustained an aspirational pneumonia. Finally, sexual function. Now that should be pretty much normal, but of course that needs to be talked about. We advise them when they're leaving rehab that there's no risk of them having another stroke when they have sex, and that there's whilst they might need to change positions if they're having difficulty balancing, there's no reason that they can't return to normal sexual function. And we make sure that we check to make sure that patients can lubricate or get erections and ejaculate, because they would be suitable for sexual assist, for counselling to assist them in managing normal sexual behaviour. Now, I want to turn your attention to the Stroke Foundation. The National Stroke Foundation has a whole heap of resources available to patients and to GPs, including the guidelines, to make you understand what you can do in the community, and also will tell you what the closest rehab hospital is. The Rehabilitation Medicine Society of Australia and New Zealand and the Australian Faculty of Rehab Medicine at the Royal Australian College of Physicians will also give you advice on the local rehab physician. So, carotid artery dissection or vertebral artery dissection as a cause for stroke causes pain. Now, this is quite interesting because mostly when strokes occur, pain is not a feature. When pain is a feature, you're either dealing with an aneurysm that blows and causes the pain on the meninges, or you're dealing with a carotidynia, or a vertebral artery spasm that gives you pain in the neck due to the dissection. Now, chiropractic and massage for people's neck have been very controversial. There is a number of reported cases where people go to the chiropractor and then end up with a dissecting aneurysm and come in and have a stroke. The chiropractors, particularly in the United States, say this is a chicken and egg story, because the reason that they came to us is because they had neck pain from their dissecting aneurysm. We didn't know, and we gave them a manipulation. I think the bottom line is going to a chiropractor that does cervical manipulation at any stage is not helpful, and it actually is, there's no evidence that the other treatments in chiropractic like massage are not just as good as manipulation. So massage and chiropractic where there's manipulation still needs to be avoided, but it is controversial. NOACs are being used for carotid artery and vertebral artery dissection, but the evidence is they're no better than antiplatelets. And the current studies have shown that antiplatelet drugs are just as good as NOACs. So you have to have another reason to be on a NOAC or warfarin. Quality of life worsens, particularly with symptoms of PTSD in these vessels. So a lot of these young people who get these tears of the blood vessel, they have a horrible, shocking time in the hospital. They go to ICU. They have to see people like Kartik and have terribly risky procedures. And so they often have PTSD. There's no evidence in these cases that endovascular treatment are better than thrombolysis for outcomes. So that's still being discussed and controversial. And there's no evidence that of direct effects on rehab of ataxia. So ataxia is still treated in a compensatory manner where we just teach them how to prevent falls. Swallowing therapy is successful but prolonged. So here's a nice vessel, a nice picture of the major vessels. Those are the two internal carotids coming up. Here are your vertebrals. There's your basilar. These are the picas coming off here, your other small vessels about basilar. You can see that stenting the basilar is impossible because you'll block off all these arteries that are going to your brainstem. And here's your posterior cerebral arteries and the posterior communicating. So I'm going to finish up there, and I'm happy to have any questions if you need to ask any.
Great, thank you. If you do have any questions, please type them into the questions tab. We'll just wait a few minutes. We did actually have a question for the first speaker. Dr. Baita, if you want to turn your microphone on.
Okay, I'm on now.
Yep, and so the question was, how does one know that there are two siblings affected if the patient's siblings are not screened?
Yeah, I mean, that's the big problem. If they're not screened, you may never pick it up. You may never pick up a familial cluster. And this is one of the problems with all the family history studies, because you can have centers which have like thousands of patients who they've treated, and then they look through all their patients, and when they find the number who have two diagnosed aneurysms in the same family, it comes down from what started with a list of 2,000 patients, comes down to like 12 families. And that's why the family history studies have been so hamstrung. I think that essentially you're dealing with people who you will often get a mixed history. They'll say, my father died of a stroke, and you ask them later, what kind of stroke did they have? Oh, it was a bleed in the head. Oh, do you know what caused the bleed? Was it an aneurysm or was it something else? And you'll often never get the answer. And unfortunately, you can't change your risk assessments based on it, because probably it was a hypertensive hemorrhage. So the answer is, unless the patient, unless one of them presented to their doctor for another reason and had an MRI for another reason, they found an aneurysm, and then the second sibling had a subarachnoid hemorrhage, you otherwise won't pick it up. And that's why it's actually quite uncommon to pick up these families, and why I offer screening to people who are considering it after I have a discussion with them about the pros and cons. But I agree with you, it's very uncommon to find the family clusters, because people just don't end up getting screened. Does that answer that question?
Great, I believe it does. It doesn't look like we've got any other questions. So if you do have any last minute questions, please submit them. Otherwise, I think the topics were just fantastically covered tonight. So thank you very much to both speakers. And thank you everybody for attending, and also for your support throughout the year. So if there's no other questions, we might end the presentations there. Thank you again, and please visit our website to view and register for any upcoming events. And thank you, and have a great night, everybody.